Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be explaining you different types of jaundice and how to differentiate between them and what are the diagnostic features for all these types of different types of jaundice. Now let's get into the details. Now, how to approach to a patient who is having hyperbilirubinemia. So, hyperbilirubinemia, that means excess bilirubin levels in the blood. So, how to diagnose a person having hyperbilirubinemia and how to differentiate what are the causes for that hyperbilirubinemia. So, hyperbilirubinemia, that means excess bilirubin in the blood, may result from one of the following reasons, and that is it can be overproduction of bilirubin, simply excess bilirubin is being made, or it can be impaired uptake or conjugation of bilirubin in the liver, or it can be impaired excretion of bilirubin from the liver, or it can be regurgitation of unconjugated or conjugated bilirubin from the damaged hepatocytes or bile ducts. So, these are the different causes from which hyperbilirubinemia can happen. That means overproduction of bilirubin. Excess bilirubin is made in the spleen and which goes beyond the capacity of the liver to conjugate it. That's one cause. Second is it can be a liver issue where liver is failing to uptake that bilirubin, or even if it is taken up, it may fail to conjugate the bilirubin, converting unconjugated into conjugated bilirubin there. Or there may be issues with the secretion of bilirubin from the liver into the biliary canaliculi, or it can be damage to the biliary canaliculi or obstruction in the common bile duct that may lead to regurgitation of bilirubin, which may be conjugated or unconjugated back into the blood, leading to hyperbilirubinemia. So, we have four causes for hyperbilirubinemia here. If there is any defect in cause 1 and 2, reason 1 and 2 above, that is overproduction of bilirubin, impaired uptake or impaired conjugation of bilirubin, in these causes there will be predominantly elevated unconjugated bilirubin. So, these two causes will lead to unconjugated hyperbilirubinemia. Okay. Now, if the reasons are because of number 3 and number 4, that is impaired excretion of bilirubin or regurgitation of bilirubin from the biliary canaliculi or common bile duct, these two causes will lead to increase in conjugated bilirubin. So, this is how we can differentiate. Okay. So, predominant unconjugated hyperbilirubinemia is because of overproduction of bilirubin or impaired uptake of bilirubin or impaired conjugation of bilirubin, or it can be because of defect in the excretion of bilirubin from the hepatocyte or regurgitation of the secreted bilirubin from the common bile duct will lead to predominantly elevation of conjugated bilirubin. So, based on these four reasons, let's look into different types of jaundice now. So, first let's look into pre-hepatic jaundice or hemolytic jaundice, that is overproduction of bilirubin. So, hemolytic process results in an overproduction of bilirubin, and this hemolytic process can be acquired hemolysis or it may be inherited hemolysis. And inherited hemolysis includes any genetic disorders where there can be increased lysis of red blood cells. Some of the disorders that I have mentioned here where there will be hemolytic anemia, that is inherited hemolytic anemias that you can see, is spherocytosis, that is hereditary spherocytosis, hereditary elliptocytosis, can be G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, or it can be pyruvate kinase deficiency, sickle cell anemia, different types of thalassemias. All of them will fall under inherited hemolytic disorders leading to hyperbilirubinemia, that's a overproduction of bilirubin. Or it can be acquired hemolytic disorders that include microangiopathic hemolytic anemias like hemolytic uremic syndrome, paroxysmal nocturnal hemoglobinuria, spur cell anemia, immune hemolysis like RH incompatibility, ABO incompatibility. All these are acquired hemolytic disorders, again leading to overproduction of bilirubin. Now, there can be ineffective erythropoiesis also. That means red blood cells are made, but they will be destroyed because they are simply not a normal red blood cells. So, that type of ineffective erythropoiesis can be found in cobalamin deficiency, folate deficiency, iron deficiency, where inability of the bone marrow to produce a mature red blood cells can be seen, and physiological hyperbilirubinemia seen in physiological jaundice of newborn. So, in all these conditions, there will be elevated levels of predominantly unconjugated bilirubin. Note that all these are the causes for elevated levels of or overproduction of unconjugated bilirubin. That means there will be so many red blood cells are dying, and the capacity of the liver to conjugate the unconjugated bilirubin, it just exceeds. So, because so much unconjugated bilirubin is carried to the liver simply fails to conjugate all that bilirubin that is coming into the liver. So, that leads to elevation of UCB, unconjugated bilirubin in the blood. So, that is what is the cause for isolated elevation of UCB or unconjugated bilirubin. So, what are the causes for isolated elevation of unconjugated bilirubin, which is referred as pre-hepatic jaundice, because it is all the things are before the liver. Okay, so there is excess bilirubin formation in outside the liver, where liver is failed to conjugate all of it. Okay, so all kinds of hemolytic disorders, you can put it into pre-hepatic or hemolytic jaundice, or it can be cobalamin deficiency, folate deficiency, iron deficiency, all of them, including physiological jaundice, they all fall under pre-hepatic jaundice. So, what we are going to see here in pre-hepatic jaundice, what are the laboratory features that we see in pre-hepatic jaundice? So, in pre-hepatic jaundice or hemolytic jaundice, serum total bilirubin rarely exceeds 5 mg per deciliter. Just in case if it exceeds more than 5 mg per deciliter, so it may be associated with any hepatocellular dysfunction in handling bilirubin, can be hemolytic crisis also. So, they will have higher incidence of pigmented gallstones, that is calcium bilirubinate stones can be found in hemolytic jaundice or pre-hepatic jaundice, because excess levels of unconjugated bilirubin, so which is conjugated at maximum rate in the liver, and that conjugated bilirubin can be part of the gallbladder, and the gallbladder, when it is concentrated, when the contents in the gallbladder is concentrated, and when the calcium is precipitated, the calcium bilirubinate stones can be found in hemolytic anemia patients. Okay, you got to look for that. Now, let's understand the pre-hepatic jaundice or hemolytic jaundice, where there is a unconjugated hyperbilirubinemia seen. So, using the figure that I have explained in the previous lecture. Okay, so in pre-hepatic jaundice, unconjugated bilirubin is predominantly elevated. That's why it is shown as 2+, which is abnormal. Normal is 1+, remember that. So, conjugation is going on in the liver. In fact, maximum amount of conjugation is going on, and that will correspondingly increase conjugated bilirubin 2+ there, and that is secreted into the intestine. 2+ Cb is going into the intestine, and 2+ UBG is made in the intestine, that is urobilinogen is 2+. Normal is 1+, because simply too much of conjugated bilirubin is coming out of the liver, getting into the duodenum. So, 2+ UBG. In that 2+ UBG, 80 to 90% is going out in the feces. So, the color of the stool is dark. So, dark stool. So, you can write it as dark stool. Dark colored stool is one of the feature of pre-hepatic jaundice, because more and more urobilinogen is found in the stool, and accordingly 10 to 20% is reabsorbed back into the enterohepatic circulation, and in that less than 3 mg per deciliter accordingly going out into the urine. So, urine urobilinogen is 2+, that means urine color is also dark. So, dark colored urine. So, in pre-hepatic jaundice, you are going to see dark colored stool and dark urine. Dark stool and dark urine. That is the findings seen in pre-hepatic jaundice or hemolytic jaundice. Now, What about conjugated bilirubin in the urine? It is 0. So serum values, conjugated bilirubin is less than 20%. Conjugated bilirubin is less than 20% there. AST is 1 plus, ALT, ALP, GGT, it is all normal. Okay. So serum values are fine there, except there is elevated levels of unconjugated bilirubin. So UCB is elevated in pre-hepatic jaundice, CB is normal. Okay, UBG, urobilinogen in the urine is elevated, and stool is dark. So dark stool and dark urine. Okay, these are the findings that you see in pre-hepatic jaundice or hemolytic jaundice. Now coming to other disorders which fall under pre-hepatic and hemolytic jaundice, where there is a isolated elevation of unconjugated bilirubin, that is impaired conjugation of bilirubin in the liver. So which is cause number 2 or region number 2, right? Impaired conjugation. So if there is a impaired conjugation, it may also lead to elevated levels of UCB in the blood. So there are 3 genetic conditions that will lead to impaired conjugation of bilirubin in the liver, and they are Crigler-Najjar syndrome type 1, Crigler-Najjar syndrome type 2, and Gilbert syndrome. So all of them, they are related to UGT1A1 enzyme, that is UDP glucuronosyl transferase 1A1 enzyme expression. Let's look into each one of these diseases. So the first one is Crigler-Najjar syndrome type 1. So the Crigler-Najjar syndrome type 1 is because of complete absence of UDP-GT1A1 enzyme. That means no enzyme activity is found here. So this is the conjugating enzyme in the liver. So if that enzyme is totally absent, so there will be severe unconjugated hyperbilirubinemia, which will exceed 25 milligram per deciliter. So UCB exceeding 25 milligram per deciliter. So you know, whenever unconjugated bilirubin exceeds more than 25 milligram per deciliter, it will lead to kernicterus. It is going to cause a neurological issue, that is kernicterus. And also phenobarbiturates will fail to induce UDP-GT1A1 because the gene for that is completely mutated and absent. So phenobarbiturates have no effect in Crigler-Najjar syndrome type 1 because phenobarbiturates fail to induce UGT-GT1A1 enzyme. So only treatment for Crigler-Najjar syndrome type 1 is orthotopic liver transplantation. Remember that. Now let's move on to see Crigler-Najjar syndrome type 2. Crigler-Najjar syndrome type 2 is because of deficiency of UDP-GT1A1. Unlike type 1 is completely absence of UDP-GT1A1. Here in type 2 it is deficiency, and it's a less severe condition compared to type 1. And here the unconjugated hyperbilirubinemia, that is increase in UCB, it is usually less than 25 milligram per deciliter, less than 25 milligram per deciliter. That means there is a decreased risk or no risk of developing kernicterus in Crigler-Najjar syndrome type 2. So UDP-GT1A1 activity can be induced by administering phenobarbiturates because the defect in the gene can still be induced. Their activity of UDP-GT1A1 enzyme can be brought up by use of phenobarbiturates. So it responds to phenobarbiturates. So that's the difference between type 1 and type 2. Type 1 do not respond to phenobarbiturates and patients are at risk of kernicterus, whereas in type 2 patient responds to phenobarbiturates and there is no risk of kernicterus. Remember that point here. Now coming to Gilbert syndrome. Gilbert syndrome is very common compared to Crigler-Najjar and type 1 and type 2. 3 to 7% of population may have Gilbert syndrome, and it's a male predominance is there. Male to female ratio is 7:1 there, and reduced activity of UDP-GT1A1 is seen here because of mutation in Tata box and all that. So impaired conjugation of bilirubin in the liver is seen, and the type of UCB, unconjugated bilirubinemia, is usually less than 6 milligram per deciliter. Okay. So normally unconjugated bilirubin is 0.8 milligram per deciliter. So less than 6 milligram per deciliter UCB, unconjugated hyperbilirubinemia seen here, and patients generally lives normal life except for isolated hyperbilirubinemia. Sometimes there may be a jaundice seen in these patients, especially during periods of fasting, because during periods of fasting there can be induction of cytochrome P450 type of enzymes, so for detoxification process and other things. So because heme synthesis and all that, it will be induced during fasting condition. So that may lead to elevation of jaundice. So that's about Gilbert syndrome. Now let's move on to see another type of hemolytic jaundice is a physiological jaundice of newborn. So the physiological jaundice of newborn is generally seen in premature infants or neonates, which are premature neonates are at high risk of physiological jaundice. Although physiological jaundice is seen in most of the newborns, but usually it resolves within 10 days. So if the jaundice do not resolve within 10 days, that is called as pathological jaundice. So newborn will show transient jaundice between 24 hours of life and resolves within 10 days, and that is because of insufficient UDP-GT 1A1 activity in the liver to handle all the unconjugated bilirubin that is brought to the liver. Because remember, when the birth occurs, the red blood cells containing fetal hemoglobin need to be replaced by red blood cells containing adult hemoglobin. That transient change has to go on. That means all the fetal hemoglobin containing red blood cells need to be killed and replaced by red blood cells containing adult hemoglobin. So when that is going on, so more and more hemoglobin is undergoing degradation, making more unconjugated bilirubin, which is brought to the liver, and liver has to handle conjugation process, which may not be possible sufficiently. So that's why there will be increase in unconjugated bilirubin transiently for around 10 days, from 24 hours of life until 10 days. That's what is the physiological jaundice of newborn. Okay, so unconjugated bilirubin, sometimes it can reach more than 25 milligram per deciliter, especially in premature neonates, and that will put them at risk of kernicterus. So how to treat that kernicterus? So treatment and also physiological jaundice of newborn. So usually phototherapy, or that's a UV light, blue light therapy is done, because what blue light does is going to convert unconjugated bilirubin into water soluble photoisomers. So blue light or the UV light, it's going to break that unconjugated bilirubin into photoisomers, and which are water soluble and excreted out of our body. If the phototherapy do not bring down unconjugated bilirubin levels to the desired range, at that time exchange transfusion is also done. Now any jaundice that appears before 24 hours and if it takes more than 10 days to resolve, consider that as a pathological jaundice. Generally physiological jaundice resolves within 10 days, and usually it appears after 24 hours but resolves within 10 days. So that is about isolated unconjugated bilirubin levels. Now let's look at Dubin-Johnson syndrome. Now the Dubin-Johnson syndrome, it is because of mutation in a gene that is coding for MRP2 or MOAT. Alright, now let's look into isolated elevation of conjugated bilirubin, that is hepatic jaundice. Okay, so one of that example here is Dubin-Johnson syndrome. So it causes an asymptomatic jaundice in the second decade of life. So it follows autosomal recessive mutation in MRP2 or MOAT transporter, that is a multi-drug resistance protein like 2 or multi-specific organic anion transporter. So the mutated protein here, it causes altered secretion of conjugated bilirubin into biliary canaliculi, and patient shows a darkly pigmented liver on gross inspection, and liver may be enlarged, and histopathology of the liver shows central lobular dark pigment granules, which are basically polymers of epinephrine metabolites. Okay, so coming to a similar condition called Rotar syndrome, and that is due to a defect in hepatic storage of bilirubin. So bilirubin values range from 2 to 5 milligram per deciliter, and other liver functions are normal here, and liver is greenish but no pigment like Dubin-Johnson syndrome is seen here. So overall, Dubin-Johnson syndrome and Rotor syndromes are almost asymptomatic conjugated hyperbilirubinemia conditions. Now let me take you into hyperbilirubinemia with abnormal liver function test. Basically, I will be explaining you hepatic and post-hepatic jaundice now. First, let me take you into hepatocellular pattern of jaundice. So in the hepatocellular pattern, there will be combined hyperbilirubinemia. That means there will be rise in conjugated bilirubin and also there will be rise in unconjugated bilirubin. Both the types of bilirubin will be elevated in hepatocellular pattern, and also because the liver is affected here, so that's why the liver enzymes will also be elevated in this type of jaundice. That is, aspartate transaminase and alanine transaminase levels will be elevated out of proportion to the obstructive enzymes like alkaline phosphatase or gamma glutamyl transpeptidase or 5' nucleotidase. These three enzymes, they indicate obstructive pattern, that is obstruction in the biliary canaliculi or obstruction in the common bile duct. So the obstructive pattern of enzymes, when you compare with the hepatocellular enzymes like AST and ALT, so in the hepatocellular pattern of jaundice, AST and ALT will be elevated out of proportion to ALP, GGT and 5' nucleotidase. So some of the hepatocellular conditions that may lead to jaundice are viral hepatitis, all kinds of viral hepatitis, that is hepatitis A, B, C, D, E, and then Epstein-Barr virus. It can be cytomegalovirus, herpes simplex virus, or it can be alcoholic hepatitis, cirrhosis of liver, drug toxicity. So toxicity because of acetaminophen, isoniazid, vinyl chloride toxicity, mushroom poisoning like Amanita phyllates mushroom, Wilson's disease or autoimmune hepatitis, all of them will lead to hepatocellular pattern of jaundice. And patients will show generalized liver dysfunction involving uptake and conjugation of unconjugated bilirubin, secretion of conjugated bilirubin into the bile ducts, and recycling of urobilinogen. So all of that will be affected in hepatocellular pattern of jaundice. So that means there will be rise in CB, there will be rise in UCB, there will be rise in UBG urobilinogen, there will be increase in AST, increase in ALT, alanine transaminase. So, and that it may also show decrease in globulins and albumin and globulin. So indicating liver function is decreased. So these are some of the findings that you see in hepatocellular pattern of jaundice. So here is the figure that will help you to understand all the things that we have seen before. So unconjugated bilirubin is elevated, so that is 2+ there. Liver and bile duct necrosis, so because the problem is liver, so conjugation process can be affected. So that means you have 1+ CB, but the conjugated bilirubin is leaking out into the blood. So the conjugated bilirubin levels in the blood between 20 to 50, more than 20 to 50% of total bilirubin. Normally, you see conjugated bilirubin is usually less than 20% of total bilirubin. Now it is 20 to 50%. And also look at CB 1+, UBG 1+, but enterohepatic circulation is kind of affected here. So UBG is 20 to 20% of the UBG that has to be uptaken by the liver, so that doesn't go on. So most of it is just going into the feces. So still you see dark colored stool can be seen because of UBG more in the stool and also UBG more in the urine. So dark color urine, dark, or it may be normal stool because most of the UBG is directed towards liver, not taken up by the liver but going towards the kidney. UBG dark urine, so normal stool and dark urine. And CB is also CB, conjugated bilirubin is 2+ because conjugated bilirubin in the blood is more than 20 to 50% of normal. Normally it is less than 20%. So renal threshold is exceeded here. 20 to 50 conjugated bilirubin in the blood means it will appear in the urine. So urine has both urobilinogen present, as you see here, and conjugated bilirubin is also present. Normally you don't see conjugated bilirubin in the urine. There are 2 plus conjugated bilirubin in the urine. That makes urine dark in color. So dark urine, and color of the stool can be normal. So normal colored stool and dark urine. And look at serum enzyme levels, AST and ALT. It is elevated. ALP and GGT, all the elevated, but not like AST and ALT. So AST, ALT elevated out of proportion to ALP and GGT. So these are the some of the findings that you see in hepatocellular pattern of jaundice. So you see both elevated UCB, elevated CB, and then elevated UBG in the urine, elevated UBG in the urine, UBG in the urine elevated conjugated bilirubin in the urine. So that means dark urine. So normal stool and AST and ALT level elevated, both AST ALT elevated out of proportion to ALP and GGT. So these are the findings that you see in hepatocellular pattern. Coming to cholestatic pattern of jaundice, means obstructive pattern. So obstruction to the flow of bile results in systemic retention of bilirubin, bile acids, bile salts, cholesterol and cholesterol esters. All these molecules will tend to be accumulated, and accumulation of these things may lead to certain signs and symptoms. So cholestatic patterns can be of two types, that is intrahepatic cholestasis, that means biliary canaliculi are blocked, or it can be extrahepatic cholestasis, that is common bile duct is blocked. So intrahepatic cholestasis, where intrahepatic biliary ductules are blocked, and that is caused because of some drugs, viral hepatitis, biliary atresia, primary biliary cirrhosis, sclerosing cholangitis, all these are the causes for intrahepatic biliary duct obstruction. Extrahepatic cholestasis common cause for that is stone in the common bile duct or pancreatic cancer in the head of the pancreas. It may lead to extrahepatic cholestasis. Okay, so whether it is intrahepatic or extrahepatic cholestasis, so there will be rise in the serum and urine bilirubin level, because serum bilirubin level will be exceeding more than 50% of the total bilirubin is conjugated bilirubin. So it is a predominant conjugated hyperbilirubinemia. Cholestatic pattern is conjugated hyperbilirubinemia more than the unconjugated form. And since there is more conjugated bilirubin is there in the blood, so conjugated bilirubin appearing in the urine at high concentration. So urine is dark. So dark urine or cola colored urine, sometimes it is referred as. And if there is a blockage in the common bile duct, totally it is obstructed, so that conjugated bilirubin do not appear into the intestine. So there is no urobilinogen. So no UBG. No urobilinogen is there made in the intestine. So that means stool is clay color stool or colorless stool. So that's what is shown here, clay colored stool, clay color stool, because urobilinogen is not there. So urobilinogen you don't find in the urine also, but still urine is dark in color because conjugated bilirubin is more. And also look at the serum values here. So conjugated bilirubin is elevated, AST is just 1 plus, ALT is just 1 plus, because it's not a hepatic pattern, it's a cholestatic pattern, it is obstructive pattern. So that's why ALP is elevated out of proportion to ALT. So ALP, GGT elevated, and 5' nucleotidase enzyme is elevated. So ALP, GGT, 5' nucleotidase, all of them elevated out of proportion to AST and ALT. Conjugated bilirubin is elevated, and no urobilinogen, clay colored stool, dark colored urine. All these are the findings that you are going to see in cholestatic pattern. Along with that, patients will also show jaundice with pruritus, one of the important signs that you got to see here. Patient will show jaundice, yellowish discoloration of the skin, and also they will feel that there is a itching going on over their skin. So pruritus, generalized pruritus, and pruritus is due to bile salts deposited in the skin. So generalized itching all over the skin you are going to see. And also because biliary canaliculi and bile duct, common bile duct is totally obstructed if it is done, bile acids and bile salts don't reach duodenum, so they don't participate in emulsification process, and that will lead to lipid malabsorption, that is essential fatty acid deficiency and fat soluble vitamin deficiency can be seen in this particular obstructive pattern. And cholesterol deposits in the skin can be seen, leading to xanthomas, xanthelasmas, light colored stool, dark colored urine is one of the finding there, as we have already seen previously. Okay, so the laboratory findings, as I already told you, markedly increased levels of alkaline phosphatase, gamma glutamyl transpeptidase, 5' nucleotidase. All of them are markers of obstruction. You're going to see that conjugated bilirubin is more than 50% of normal. Bilirubinuria is there, means excess bilirubin in the urine. Absent urobilinogen and high serum cholesterol levels, and bile lakes you are going to see on histopathological observation, and green colored liver on gross inspection you can see there. So that is an obstructive pattern. So here is the laboratory findings in normal patients with 3 different types of jaundice is shown here. So in normal person, serum bilirubin is between 0. Serum bilirubin, direct bilirubin is 0.1 to 0.4 milligram per deciliter. Urobilinogen is 0.4 milligram per 24 hours of urine. Urine bilirubin is absent, and fecal urobilinogen is normal, that is 40 to 280 milligram per 24 hours. In the hemolytic jaundice, indirect bilirubin, that is unconjugated bilirubin is elevated. Urine urobilinogen is increased, that is dark colored urine, and urine bilirubin is absent, and urine or the fecal urobilinogen is increased. That means dark colored urine and dark colored stool you are going to see. And the type of bilirubin elevated in hemolytic anemia, hemolytic jaundice or pre-hepatic jaundice, it is indirect bilirubin, unconjugated bilirubin elevated. In hepatocellular pattern, hepatitis, both the types of bilirubin is elevated, both conjugated and unconjugated. So urine urobilinogen decreased if micro-obstruction is present, and urine bilirubin is present if micro-obstruction is present, and fecal urobilinogen is decreased. Coming to obstructive jaundice, where direct bilirubin, that is conjugated bilirubin, is predominantly elevated, urine urobilinogen is absent, and urine bilirubin is present, that leads to that dark colored urine and traces to absence of fecal urobilinogen, clay colored stool. So this is how we can differentiate different types of jaundice, both on laboratory serum values and also laboratory urine values, and also some of the signs and symptoms according to whether it's a pre-hepatic, hepatic or post-hepatic jaundice. So that's about different types of jaundice. Thank you.